Good afternoon. I will call to order this Health and Human Services Committee meeting on February 25th, 2026 to order. As far as roll call, we have everyone here with the exception of excused absences from Supervisor Gallitz and Riley. Is that
Riley Hanson.
Riley Hanson. So thank you. We are going to, the affidavit of posting, that's right. Haven't done this for a bit. I feel like I'm catching up here. It was posted accurately to all the appropriate sources. We'll rise for a moment of silent prayer and the pledge of allegiance. I pledge
allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
So any changes or comments? Hold on, can you hear me? It's in my mic. To the minutes. Okay, seeing none, they will be considered approved. Our first agenda item is the out of home care year-end report.
Yes, thank you. And if it's all right with you, I'll just roll right into the second agenda item as well, the inpatient, since it's all in one report. Okay, great. Thank you. So as you know, this is a report that we provide to this committee. We've been doing it every 6 months for a while now. This is our end of the year for 2025. The out-of-home care and the inpatient hospitalization for our department are our two biggest drivers of our budget. And so it is something that we, monitor and try to manage as well as we can. But obviously the needs of the community dictate placements more than we can. And so I just think it's important for this committee to be aware. There's a philosophy in budgeting that happens here because as you can see in this report, what we budget and what we spend never aligns. And so the philosophy is, do you budget what you think or what has been spent, or do you budget a target, try to manage to that target, and then try to absorb the costs within the overall budget itself? So in my tenure here, it'll be 9 years in May, we've been doing the philosophy of, budget to what your target is, and then work within the budget to make sure at the end of the year, the overall budget isn't overspent. So, not before everybody gets really excited about these numbers, we have, as years pass, ended this year's budget in the black. I always want to make sure I say the right one. Slimmer margin than years past, but still feel really confident about where we are with our budget overall. But I think a couple of things that are important to know in the out-of-home care budget specifically is that we've presented to this committee about residential care placements, which are higher cost placements. And we've been working very diligently around reducing the children that are placed in residential care. We have some community-based services that we implemented a few years ago aimed at doing that. And we feel very proud that we've reduced the number of kids in residential care, because we don't think that that's where children's behaviors and family systems dynamics are really resolved when the child is just placed outside of the home and not with the family. And so however, despite, the number of kids being placed in residential reducing, we have seen the costs either stay stagnant or increase. And that is for two reasons. Number one is, since 2020, we have seen the daily rate of residential care rise exponentially, and we have no control over what a residential provider charges. There's some mechanisms at the state that helps them keep it within parameters, but their cost increase, as well as everything else that we've seen in the past several years. We also have seen that the kids that are placed in residential care are our highest acuity children. And so sometimes they need a higher acuity placement, which also has just a higher daily rate. As you recall, I think it was in 2023 and 2024, we had a couple of children placed out of state. They have returned home, but those were high drivers of our cost in those years as well. In particular, in 2025, we do have 2 youth who are now placed in Mendota Mental Health, which is a very high cost placement. That is after they were not successful in a number of placements, including Copper Lake, Lincoln Hills. And that's the only way for a youth to go to Mendota is after they are not successful in a placement like Copper Lake and Lincoln Hills. And those are not criminal. They're not placed there because of criminal needs. They're placed there because their behavior is so significant that that's where they need treatment now. And so obviously our team works very diligently in trying to ensure that those children and those youth are getting the services, the treatment services that they need so that we can bring them home and put them in, a stepped down placement. But for right now, that is where those youth are, and that we saw that as a huge increase in our residential care in 2025 in particular. Also, as you may note, in 2025, an ever increasing expenditure was our shelter care. This committee did a lot of work with me last year on analyzing the shelter care services, and I appreciate that. And so, as you can see in this report, we have had a higher cost. We knew that was happening, but then in 2026, we have closed our shelter, and we are now contracting with Waukesha County. So we'll see in the 2026 reports, you'll see, a change in those expenditures. So I'll stop there and see if there's any question about out-of-home care before I go into the inpatient hospitalization report.
Anything? Okay, good.
So very similarly, you sort of see a little bit with the inpatient and the Institute for Mental Disease, which is what the IMD is, and I apologize for not spelling that out, is sort of a variation over time. The inpatient specifically represents Winnebago and other inpatient hospitals that we contract with, so they're not all Winnebago, but we do just roll it up in one. The costs fluctuate sometimes year over year because we do receive some reimbursement for certain placements, but the reimbursement lags somewhere between 6 and 9 months. Sometimes I've seen a whole year when we've received a reimbursement. And so the way that our billing happens is we get billed for placements for the month, and then whatever reimbursement comes in comes off the bottom line. And we have no idea when and how and who we're going to get reimbursement for. It's something that Winnebago themselves manage. And so sometimes we could have a higher cost year, but the reimbursement could be higher, or we could have a low cost reimbursement year. So we sort of look at this, again, overall, the general picture, are we staying within our budget? I would say overall, I feel like outside of 2025, we've stayed within our budget, for the most part. In 2025 in particular, we have one individual that got placed in Mendota Mental Health. Well, let me step back. He was in Mendota Mental Health on a criminal charge, fulfilled his criminal requirements, but has such significant need, cannot be placed outside of Mendota at this time, has been there since August of 2024. So we've seen a full year of costs for that individual. We are working diligently with the providers at Mendota, with the providers that we work with in the community, with our criminal justice system, to try to find an option to at least do a step down for this individual. But we've really hit a lot of barriers because of this person's needs and their behaviors. And so, that is just a cost that hopefully, again, we can step this individual down to a different placement, and get them the services that they need. And then at the end of the report, you can just see sort of the overall cost summary of both of those large expenditures that we have in our budget. And so you can see 2025 was a little bit higher, but again, we have these two youth and one adult in Mendota Mental Health, which is a huge cost for us. Because even though Winnebago is a huge cost, people don't stay for, they stay for a handful of days, sometimes 30 days if it's needed. But to have people in these placements for, 365 days is a huge expense.
Any questions? Yes,
So
Supervisor
if
Bassett.
I go way back to 2016, which was before you got here. I remember we had to have an emergency county board meeting because we were $1 million over budget on our inpatient stay. And you've done a lot of work to make sure that doesn't happen again. That's all appreciated. Maybe it was more than $1 million. I can't remember for sure. It was 10 years ago, but everything you've done is appreciated. I know you do work to try to have all the alternatives in place ahead of time to prevent somebody from needing those expensive, so that's all appreciated. Question I have. So you talked about how the reimbursement is delayed. So if we incur an expense in 2025 and we get reimbursed in 2026, am I inferring correctly that counts against our 2026 budget?
Correct. So if we get a reimbursement that came from a previous year, we bill that as a revenue to the year we're in.
Okay.
And that is why, if you look at 2023, at $1 million, right? We actually were under budget. And I think that is attributed to a higher reimbursement rate that year. Mm-hmm. And then we also had a couple people that year in Trempealeau that we were able to step down to an adult family home or a CBRF, but it was primarily about reimbursement. Yeah. And some of that, is related to the individual's insurance, because if somebody's on Medicare, we get full reimbursement. But if if they have private insurance, we get some reimbursement, but we don't get reimbursement from Medicaid when they're in an inpatient setting in Winnebago.
Other locations you do get some Medicaid?
If it is a private inpatient hospital, so there are some hospitals in Green Bay and Madison that we can place them, and it's about how they're licensed.
Got it. Other comments or questions? Okay, moving on. Excuse me, to the next agenda item. Inpatient is the adult placement report.
Yeah, so as we talk about individuals who have high needs in our community and need more wraparound supports, and stepping them down from a hospital setting or an Institute for Mental Disease setting, we utilize many adult family homes or community-based residential facilities. Some people know them as group homes. They have a bedroom, they live in a house, there's 24/7 staffing, and those facilities, really help with activities of daily living, medication management, socialization, and supports. And so these are individuals who can't live fully independently with case management services because of their needs. And these placements fluctuate wildly as well. Sometimes we'll have, and sometimes people aren't successful in some placements, and we have to step them up into a higher level placement, maybe where they have one-on-one care. We've had individuals who've had to have 2-on-1 care, and then the team continues to work with them on their goals to always put them in the least restrictive environment. if you look here at the number of clients, you can see that the number of clients has not really changed over time, but the category next to it of clients who are enrolled in a managed care organization has increased. So the way you would read that is, for December, we still have 19 individuals who are in a group home-based setting, but 10 of those 19 are now with a managed care organization. And what that means is the managed care organization then pays for their costs to live in this setting. People are only eligible for a managed care organization if they have a cognitive delay or they have a physical disability. But what we see with a lot of our clients who have mental health needs or long-term substance use needs is as they get older, sometimes they then become eligible for a managed care organization because of physical limitations or sometimes, cognition, maybe their early onset dementia or things like that. And I highlight this because I think the team has done a really good job at continually assessing the needs of our clients and determining whether they think somebody then who maybe has been our client for a decade now might be eligible for a managed care organization. The ADRC does the screening for that as an independent entity, and they're very serious about it. And so they're almost like a third party of screening. So it's not a decision that we make if they're eligible for a managed care organization. But I think the teams have worked really well together to just make sure that they're identifying the needs of individuals and the services that are available to them. Because again, I mean, we as a county, we pay a yearly cost to play, so to speak, to managed care organizations so that they service our clients in our community. And so they, then that opens up a lot of more access to services, especially if people have physical limitations that managed care organizations can provide that the county ourselves don't really have the resources to do. But what you'll see here when you look at the monthly costs, those are the costs that we're expending out. We do work with our adult family homes and our CBRFs to try to bill Medicaid for some of those activities of daily living if they're in our comprehensive community services program. 90% of our group homes do bill Medicaid for us or give us the documentation to bill Medicaid. And so we are able to draw down 40 to 50% of the cost to offset these placement costs for individuals. If you look at the months of July and August and September, even as the number of clients move over to the MCOs, sometimes our costs go up, and that's where you see we have a placement that we've had to make a placement change, and they needed either a group home that had more supports that cost more per day, or we needed to do like a one-on-one care or a two-on-one care. And then as we sometimes will ramp up services for people and then work on sort of escalating them down because again, our goal is always to allow people to live in the least restrictive environment with the most independence. And so it's not something that's really easily tracked like on a one-to-one basis. Like you have 8 people and it costs this, because it's sort of always fluctuating based on people's needs.
That makes sense. And that's actually desirable, I think, to be able to be very much associated with where they're at and not so much just checking a box. So that's helpful. Yes.
I know Calm Harbor's license as a CBRF. That's not budgeted in this area, is it?
That's correct. So Calm Harbor acts as our crisis stabilization facility. And so sometimes when people are in these group home settings, sometimes they do get asked to leave because of some of their behaviors or some of the challenges that they're having. And so Calm Harbor does act as our sort of intermediary until we can get them another placement, because sometimes that takes several months. But Calm Harbor primarily acts as crisis stabilization in lieu of putting somebody in a hospital.
That's not in this.
That is correct.
Other questions or comments? Okay, we pretty much went through that report, number of clients. So if someone is, as you talked about, even maybe someone being with you for a decade or so, are they evaluating if that person is rolling into a Medicare age and then would get some reimbursement and they were previously Medicaid, or is there?
So that would be if they were Medicare eligible based on their age and determining and based on their need, if they needed skilled nursing, then that's where we would work with Medicare. Medicare really only reimburses for skilled nursing or sometimes assisted living. And so if somebody got into that area of need, we would look at that. And that does happen sometimes as well.
I just thought
Yeah.
related to the reimbursements that if you could get something instead of nothing.
Yeah.
Okay.
And I think, as much as we can, we try to also keep our clients within the county, but some of these placements are out of county because it's based on their needs and what that particular facility can provide, and then also our feelings about the facility and the quality of the services that they provide. But I think it is important to really highlight this part of the service array because I don't think very many people are aware that we as human services and the county do and are responsible to pay for the placement of some individuals who just can't live independently. But again, it's not everybody. They have to be in programming with us and services with us because they're getting that full comprehensive case management. A lot of times they're getting their psychiatric care with our psychiatrists within our clinic and things like that.
Okay. Any other questions, thoughts? Okay, moving on to the next agenda item then would be the co-responder report or CREW.
Yeah, so this is I think I presented the last quarter early in the fall of the CREW data. And so this is just a follow-up to the fourth quarter of the year. I shared at the last committee meeting the pilot that we're doing with West Bend. And so we talked at the last quarter presentation of this data about the efforts that we're making to continue to engage other law enforcement jurisdictions in calling CREW out and engaging them in the needs in their community. And we have seen a really good increase, both in productivity of the teams, but then also of additional jurisdictions calling and asking for CREW. You won't see West Bend change that much, and that's because we're doing this pilot. And so, I don't want to give them a bad rap. So because of the pilot, they're engaging with ACS much more than CREW at this time, as we sort of look at, can we offer a long-term solution to West Bend that fits their needs more specifically.
Yes.
Can you define productivity as you are using it here?
Yeah, so it's either time doing assessments or follow up with individuals.
Okay. And for example, the person, Abby, who is 60% productivity, the other 40% of their employment is paperwork or what?
Right. So we never expect anybody's productivity to be 100% because they have time doing meetings, community presentations, and then, internal, conversations and things like that. Productivity is just the time spent client contact, and the paperwork time as well is included in that. And yes, and drive time. And I know, because this team well, they're 2 years, but but there's also been a lot of training around making sure that you're documenting your drive time and your paperwork time as well, because it's notorious that clinicians and social workers forget that piece.
Thank you.
And how long is the pilot with West Bend? What's the timeline on that?
We just met with them last week, and we have moved into the month of March, adding on an additional 8 hours. So we started with 8 hours, just one person to sort of see how it went. We add an additional 8 hours to 16. Now we're going to go to 24 hours in the month of March. So we have 3 different individuals going on 3 different dates on 3 different times of the day to sort of get a feel for, different shifts and things like that. And then we'll meet again at the end of March to assess sort of the next steps, and whether or not Chief Deering and I want to get our heads together on a either formal approach or a formal proposal.
Great. Thank you. Questions? Thoughts, numbers? It's good to see things move and move up positively. Okay, thank you. Our last agenda item is the Children's Long-Term Support Update, CLTS.
Yeah, so really great report that I'd like to share with you, and will be at this point the last time I'll give a formal report on children's long-term support. We'll come and talk to you about it, like we do all of our programs. But as you recall, we worked with this committee over the last year because we were on a corrective action plan because of our enrollment lag. And so I'm pleased to share that the state has officially taken us off a corrective action plan. So we're in good standing again. And the numbers, I think, speak for themselves. And so again, this committee has been instrumental in, in helping us to work through this, and also, approving of the positions that we had contracted out last year in our budget for 2026. So all of those staff, were retained from contract to county employees. They became county employees in January. Really, no change in service delivery. And we are now meeting the benchmark of from a program, essentially when you sign up for the program or become eligible for the program to enrollment. For the state's benchmark is 90 days. We're at 75 right now. And so as you can see, the wait list for December is 18, and our enrollment was 456. And so, from January of 2025 to the end of 2025, we've enrolled an additional 123 children. So we feel like 450 to 475 is probably what where we'll be able to maintain that program. Obviously, we're looking at it very closely. And we feel like there's still space within caseloads to add additional children as needed. And then we'll be able to monitor, now that we're not just sitting with this massive wait list that just felt like it kept growing and growing and growing. We'll be able to monitor and manage a little bit more as children, are discharged from the program and then enrolled in the program, if we needed to expand again. But I think at that point, it would be a very deliberate, like one position at a time versus the 5 that we added last year.
Any like high level thoughts as to, I know we talked throughout the year about ways to improve that number. Any high level thoughts on average, how that occurred?
I mean, I think primarily it was just having enough staff.
Okay.
But for us, it was, well, what is the number? I mean, since in the last 9 years, we started with like 4 staff and we have 16 now, right? So, really trying to get a sense of what is the number of staff and how many referrals can we be expecting for our community? Because you certainly don't want to hire 5 staff and then have people having no work to do, and then you have to lay off staff. So I think, at first our approach was sort of 1 or 2 at a time. I think I shared several months ago that when we had our first conversation with the state, when we were put under corrective action, was the first time they could articulate to me sort of what we should be expecting for a number. And then that's where we said, well, we think we probably need to add 5 staff. And so, that seems to be the sweet spot right now. And so, I think we're sitting in a good position.
Questions? Yes, Supervisor Bowser.
Are we still maintaining this as essentially completely self-funded through the reimbursements we're receiving?
Yes. And yes, I feel very confident about that. As you can see, I think at the end of the report, our hourly rate for 2026 is about $213. And the way we came up with that number is we put in all of there's a whole spreadsheet thing we have to fill out where we put in all of our costs, and then that essentially creates the hourly rate. And it's not just the cost of those staff, it's the cost of, my finance manager, the supervisors, their mileage, their training, their laptops, their cell phones. And this has been a growing and learning process with the state as well, because the way that we were even administering the program 9 years ago is completely different than the way it is now. Which many counties had that concern. Will this really pay for itself, as they say? And last year in 2025, when we reconciled 2024, was the first time that I saw solidly the dollars and cents that I felt very confident that we are getting that reimbursement. Unfortunately, it's not really unfortunately, because when you're talking about when money hits from 1 year to another, we will get a huge reconciliation payment in about April. And so last year it hit in 2025 for 2024 expenses. And so that was the first time that I felt like once we got that huge, it was like a $400,000 reconciliation payment, that I was like, we're really getting paid for our full costs. What'll be a little tricky is, we'll get our 2025 in April. That'll go to 2026 expenditures, and just making sure, because your costs last year were less than they are this year with staff salaries and things like that. But again, that's the way that we manage that, is then managing the total bottom line for the Health and Human Services budget.
Sounds good. Any other questions, comments?
So I just want to say I really appreciate the work of this committee. I know we've presented this to you multiple times, and the support that you've given. It's a complex sort of program and process to understand, because there's not a definitive, like, here's the number you're going to have. And so I appreciate that the work of this committee and the support that you've given us to get to this place. And, nobody wants to be in a place where you have under a corrective action plan. So I feel really good that we've resolved that.
Yes. We'll have to let Supervisor Gallutz know. All right. Any other thoughts, comments? Thank you for your comments, Julie. Our next meeting date will